So, dear colleagues, good morning. My task now is to talk about new developments in hormone receptor positive breast cancer. Well, as you can see, every year approximately 700,000 women are diagnosed with hormone receptor positive breast cancer. And I believe that the optimal management of these patients remains a significant challenge for all of us. In the next 25 minutes or so, I really would like to address four important clinical questions, which I hope you will find relevant for your daily clinical practice. The number one question is, what is the threshold for use of adjuvant chemotherapy in addition to adjuvant endocrine treatment? The second question, which are the most efficient endocrine strategies on average? The third question, one of the most difficult ones, is can we tailor adjuvant endocrine therapy in daily clinical practice? And I will finish by saying a few words about some possible innovative approaches to new drug development for this particular subgroup of patients. So the threshold for using adjuvant chemotherapy in addition to adjuvant endocrine treatment, I think, remains one of the most controversial issues in the treatment of women with breast cancer. So what I'm going to do is share with you my own biased interpretation of the available data. So the first thing I am doing in the clinic is really to start by focusing on biology first. So I don't focus initially on tumor size and nodal status. The first question I ask myself is endocrine therapy for this woman going to be the most important treatment modality? And to answer this question, I use this elegant definition of endocrine responsiveness that was proposed by the Singalon 2007 panel of experts. So what you see here is that, of course, endocrine responsiveness is a continuum. But the tumors with the highest degree of endocrine responsiveness are those which satisfy all the criteria listed on the slide. So this must be tumors with a very high expression of both ER and PR. They should not have a high content in UPA-PI1 if you measure these two biomarkers. They should not be overexpressing HER2, and they should not show increased proliferation. So that's relatively easy. The problem starts for tumors where one of these criteria is not met. Then you are in this gray zone where you cannot be fully confident that endocrine therapy is going to do an excellent job. And then, of course, we will discuss this further. I thought that it was quite interesting to see that already in 2007, proliferation markers were recognized as playing an important role there, and we will come back to this. Okay, so now, clearly, I think that the chemotherapy indications are somehow going to follow an inverse pattern in relation to endocrine responsiveness. So the less endocrine responsive a tumor, the higher the indication for chemotherapy. But of course, the threshold to recommend the use of adjuvant chemotherapy remains very difficult to define. So in the Singalon 2009 recommendations, first of all, adjuvant chemotherapy was considered to be an option for tumors showing high endocrine responsiveness if tumor burden starts to become a real problem. So tumors larger than 5 centimeters, extensive peritumoral vascular invasion, or tumors that have invaded at least 4 positive nodes. And interestingly also, there was a recommendation that you could start using, if available and affordable, the multi-gene prognostic signatures if, after considering all these factors, you would still have a doubt as to whether or not chemotherapy should be proposed to the individual patient. So let's discuss for a few minutes these multi-gene prognostic signatures. There are several of them which have been shown to be extremely powerful prognostic markers of clinical outcome. And interestingly, the common denominator of these prognostic signatures is a bunch of proliferation genes. And our group has shown that it's really these proliferation genes which are carrying the prognostic power of the signatures. As we will discuss later, the clinical utility of these multi-gene prognostic signatures is largely restricted to ER-positive disease, and we will see why in a minute. Now, I like to look at the signatures the other way around. I think that what they are going to be most useful at is in identifying a group of tumors at low risk of relapse, and also, and I have no time to review all these data, what some studies have started to indicate is that these tumors, which show very low proliferation, usually are endocrine responsive and are not very responsive to chemotherapy. The problem with all these studies is that they are based on retrospective material. And clearly, the prospective validation of the predictive value of these multi-gene signatures is ongoing through the conduction of these two very important clinical trials that we discussed already yesterday, TAILORx looking at Oncotype DX and MINDACT looking at MammaPrint. So as you know, TAILORx is primarily looking at the role of chemotherapy in tumors showing an intermediate recurrence score. And MINDACT, in fact, is designed to show the safety of trusting the signature in discordant cases. So we hope to demonstrate that the signature is more reliable than the clinical risk based on adjuvant online. And for about 1/3 of tumors, we get discordant information, and when we get discordant information, most often the situation is that the signature indicates a low risk, while adjuvant online indicates a high risk. Now, we have to recognize the fact that tumor burden remains important, but of course, it is not a target per se. So what you see on the left is a multivariate analysis that we did in the context of a large meta-analysis of studies with gene expression profile of early breast tumors. And clearly, the gene expression profiles, using lots of the published signatures, were strongly associated with clinical outcome, but they did not wipe out tumor burden. So nodal status and tumor size remained prognostic in this model. When you look now to the right part of the slide, I think that this is a very elegant demonstration that tumor burden matters in terms of prognosis. So the vertical axis is the risk of developing distant metastasis in the ATTACK trial, so a trial where women received endocrine therapy, and the horizontal axis is the value of the recurrence score. And then you see three curves, a yellow and a blue curve, and a green curve. And this is a breakdown of patients according to nodal status. So if we now concentrate on women with a very low recurrence score, what you see here is that up to 3 positive nodes, they have an excellent outcome. They have a very low risk of developing distant metastasis. But if you have a low recurrence score and 4 or more positive nodes, your prognosis when you receive endocrine treatment is not good at all. And there seems to be this big difference between 0 to 3 nodes and 4 plus nodes. So tumor burden is important. So let's examine what we are going to do in clinical practice in these two extreme situations. You have a patient with a very small tumor, no negative, but the biology looks terrible based on the signatures. And in contrast, you have a patient presenting with a large tumor, node positive, but the biology seems to be favorable. The first scenario is a little easier than the second. So for the first scenario, we start to see some interesting data indicating that when you have a bad biology, even if you present with a small tumor, you are not going to do well. So these are data based on MammaPrint, a series of close to 1,000 patients followed for 7 years. Now, 60% of these patients did not receive any adjuvant systemic therapy, and the tumor was profiled, so the patients could be divided into women with a favorable signature or an unfavorable signature. And if you concentrate on the left part of the slide, the small T1A-B tumors, you see that there is a striking difference in distant disease-free survival between those who have a good profile. They have a 93% chance of being free of distant metastasis at 7 years, while the others have a 78% chance of being free of distant metastasis at 7 years, and many women would not accept a risk as high as this one. Now, it's interesting to see that the NCCN guidelines have already produced this type of table, indicating that indeed in small tumors, node negative, when you have the information that there is an aggressive biology based here on oncotype DX, you should give treatment. But you see that for the T1A tumors, there is a consensus that here biology should not really play a role, and these women should not be treated. And a same recommendation was made by the Single Island Consensus Panel. For the T1A, you can omit systemic treatment. Okay, we have discussed these provocative data of the SWOG trial yesterday. Let me summarize them again for you, because they are really bringing an interesting message. So this was a trial, as you know, pretty large trial for postmenopausal women with hormone receptor positive disease and node positive disease, looking at the benefit of CAF chemotherapy on top of tamoxifen. And this is an unplanned retrospective subgroup analysis done on tumor blocks that were available for measuring oncotype. So what we see here first is that the 21 gene recurrence score is a strong prognostic factor. And what you see in the first graph is that the prognosis of women receiving tamoxifen alone is not good, even if they have a low recurrence score. The low recurrence score is the pink curve. And in fact, you see that these women have only a 60% chance of being disease-free at 10 years if they receive tamoxifen alone. So then you would think, let's give these patients CAF. It's going to improve their outcome. And that's where we see these provocative data. These low recurrence tumors do not seem to benefit from CAF chemotherapy. Now, of course, the problem we have here is, of course, that we are dealing with a retrospective subgroup analysis, and it's a relatively small sample size. But there is an interesting hypothesis here, and I heard that the SWOG is considering perhaps to run the definitive trial that will take these women with a low recurrence score, node positive disease, and randomize them to receive chemotherapy, yes or no. I think it's the only way we are going to have a clear answer whether or not we can withhold chemotherapy in these patients. Okay, so to make a long story short, it's apparent that the benefit from adjuvant chemotherapy differs according to the different breast cancer subtypes and is probably the lowest in the so-called luminal A cancers and the highest in the highly proliferating tumors, the HER2 positive and the triple negative. And we can easily explain this. So what you see here is an analysis of these breast tumors divided by the subtype and according to a gene expression proliferation module. And what you clearly see is that the HER2 positive and the triple negative tumors are almost always highly proliferating tumors. So these are not the tumors where you should order Oncotype because the answer will always come back high recurrence score. With a few exceptions perhaps in HER2 positive disease, but I have no time to discuss this today. But what you clearly see there is that in ER positive HER2 negative disease, this proliferation index clearly divides the population into two different diseases. We have the high proliferative tumors, luminal B, and these are the tumors where adjuvant chemotherapy provides some benefit. And then, of course, we have the low proliferative tumors, luminal A, which are the tumors for which MINDACT and TAILORix are most likely show that adjuvant chemotherapy can be safely omitted and is probably not helpful. So my way of looking at this data is that it seems that it is becoming more and more important to make this distinction between the luminal B and the luminal A cancers for clinical practice and for future research. Now, how can we distinguish these two subtypes in clinical practice today? Well, I think we are still in the era of empirical medicine and that we have two very suboptimal tools to do this. Ki-67, of course, can be used, but the problem is its reproducibility and the cutoff. I don't think that we have a clear definition of the optimal cutoff between luminal A and luminal B. Is it 10%? Is it 11%? Is it 14%? You can use tumor grade, but then you are going to be stuck with these grade 2 tumors, and I will come back to that. So if we now enter the era of precision medicine, are we going to have some better tools to make this very important distinction? And I do think that the answer will be yes, hopefully, in the coming years. I just want to show you the potential of the genomic grade index. Of course, I am biased here because it was developed by Dr. Sotiriou in my hospital. But this is a multi-gene signature that serves as a surrogate for histological grade 1 and 3. And in fact, there are no more grade 2s because if you look, the gene expression profile of grade 2 tumors is superimposable either to the grade 1 or to the grade 3. So this is a very useful new tool. It is strongly prognostic. You see that in the curves shown on the top right. And interestingly, when you do a parallelism with the molecular portraits of Dr. Peru, the genomic grade index can separate very clearly the luminal B with a high genomic grade index and the luminal A with a low genomic grade index. Now, this is an interesting work done by one of my fellows and presented in San Antonio. What was done there was an analysis of the usefulness of several multi-gene prognostic signatures, including the genomic grade index. And this was done using data available on the web. And the confrontation was between the signatures and the histological grade as defined by local pathologists. So what you see is that in the grade 2 histological tumors, the signatures are really useful. Interestingly, they are not very useful in the grade 3, suggesting that the pathologist has no difficulties in identifying the bad tumors. And what was the surprise for us was that the gene expression signatures seem to be useful in the grade 1 tumors. So there must be still a problem for pathologists to identify grade 1 versus grade 3 in this particular subgroup. So I believe that the pathologist will need the microscope still for many years, but that it is time that he uses some additional tools, and this is going to be the price to pay for precision medicine. So if we come back to this particular slide, I think that the high proliferative tumors, luminal B, represent the best population for trials of signal transduction inhibitors. If we have not seen yet progress with anti-HER1 and other drugs in this population, I think it is because we have taken all patients in these trials, and we should have enriched the populations for the luminal B cancers. Now, the luminal A cancers will also represent a significant challenge for us in the future, because if these patients present with a high tumor burden, 4+ nodes, they don't do well with endocrine therapy, the benefit from chemotherapy is either very minimal or inexistent. And so we will have to understand the biology of these cancers to improve the prognosis. And I think that we will have to study these tumors for possible epigenetic changes. And perhaps these are cancers where we should start looking at microRNA as a way to perhaps identify new targeted therapies in the future. Okay, now very quickly, what have we learned from all the adjuvant trials with aromatase inhibitors in terms of what is the most efficient endocrine strategy on average? The puzzle here is extremely complex because you see that essentially 4 different strategies have been explored. The upfront head-to-head comparison between tamoxifen and an AI, the sequential strategy starting with tamoxifen, and the reverse sequential strategy starting with an AI. I think this combined analysis of ATAC and BIC198 is a quite useful exercise that has been done by a group of investigators led by Mitch Dorset. And essentially what you see here is that when you compare the upfront administration of an AI with tamoxifen, essentially there is a reduction in all breast cancer-related events, which is small in magnitude, but statistically significant. You can show this visually. So this is the reduction in recurrence that you see when you use an AI. In absolute terms, it's a relatively small benefit. It is statistically significant. The problem is that until now, there is no significant reduction in breast cancer mortality. If we turn now to the switching trials, this is a combined analysis of IES, ABCSG8, ARNO, and ITA. Again, you see that there is a significant reduction in all breast cancer-related events, and if you show that visually, you see that the magnitude of benefit appears to be somewhat larger, but of course there is a selection of patients here, and I think that these trials somehow must have been enriched with luminal A cancers, because of course patients did not experience an event for the first 2-3 years while they were receiving tamoxifen. The BIC198 study is the trial with the most innovative design. It is complex, but it is fascinating. And what we have heard in the last few months is an update of the comparison between tamoxifen and letrozole. Of course, the problem here is that patients in the tamoxifen arm crossed over to receive letrozole once the first results of the trial were presented. And the problem for statisticians is that an intent-to-treat analysis will underestimate the effect of the aromatase inhibitor, while a crossover censored analysis will overestimate the effect of the aromatase inhibitor. And so we heard in San Antonio a new way of dealing with crossover, the inverse probability of censoring weighted analysis, which would suggest that if crossover had not happened, we would see a difference in survival today in favor of the aromatase inhibitor. Now moving now to the very interesting comparison between the aromatase inhibitor and the sequencing strategies. What we have heard is that overall there are no statistically significant differences. So this is important to stress. If you look at these forest plots, you see that the lines are crossing 1, so there is no statistical significant difference. But you see a pattern emerging. When you compare letrozole to tamoxifen followed by letrozole, the pattern suggests that letrozole should be the winner. When you look at the reverse sequence, letrozole first, such a pattern is not emerging. Now, again, we have to be very cautious. We are not dealing here with very large numbers. In a graphical way, the message becomes clearer. So this is, again, the comparison of tamoxifen followed by letrozole versus letrozole. Letrozole seems to be better, and on the right part of this slide, you see the breakdown according to nodal status. And this is interesting. In node-negative disease, there is not much happening. In node-positive disease, the difference appears much more striking, suggesting that here, when you have increased tumor burden, perhaps starting with an aromatase inhibitor is a safer strategy. Now, this analysis is done on breast cancer events only. Keep that in mind, because in San Antonio, we saw these data from the TEAM trial. The TEAM trial compared exemestane versus tamoxifen followed by exemestane. It's a very large study. It's completely negative. It doesn't show a difference. And the investigators tried to reproduce the curves prepared by the statistician of the Big 198 study, and you do not see here such a nice message emerging, although when I look in the right part, I think I see a slight difference emerging in node positive. But the problem is that this analysis was based on disease-free survival and not on breast cancer-specific related events, so it's a less sensitive analysis. And finally, the interesting data of the reverse sequence, where you do not seem to see a difference. Now, the follow-up here is only 6 years, so we need to continue to follow these patients. In endocrine responsive breast cancer, you don't have the full story at 6 years. You have to wait 10, 15 years. And then in San Antonio, we also had an update of these interesting studies, IES, the switching strategy, tamoxifen, and then continuing tamoxifen or switching to exemestane. With a 7.5-year follow-up, exemestane remains superior. And we had also an interesting report on MA17, looking at the subgroup of women who were premenopausal at the time they started tamoxifen, of course became postmenopausal when entering the trial. These are 889 women, and what we heard in San Antonio is that they show a very large benefit from the switching strategy, even larger than the postmenopausal patients, and even if they were not negative at the beginning. So the important messages here for clinical practice are that probably young women derive a large benefit from this late switching strategy, even if not negative, and we really need to start clinical trials designed for these patients. And then switching from letrozole to tamoxifen after 2 years does not seem to be detrimental within 6 years of follow-up. Is there a more efficient endocrine strategy on average? Well, I think for me it's unclear in node-negative disease, but perhaps with the data available today, it is a little safer to start with an AI in node-positive disease. Can we tailor adjuvant endocrine therapy? Very quickly, the answer, of course, is no. We could do that potentially using information coming from the tumor or from the host, from the patient. Now, Dr. Viale has been the very first one to show this provocative data in suggesting that when Ki-67 increases, you start to see a difference in efficacy between tamoxifen and letrozole, and the better drug seems to be letrozole in the presence of a high Ki-67. Again, it is a subgroup analysis unplanned. I will skip this one because of time constraints. And then in San Antonio, we heard 3 interesting presentations looking at several biomarkers to try to see if we can tailor adjuvant endocrine therapy, make a choice between tamoxifen, an AI, or a sequence. We need to see the publication of these trials, but I am optimistic because I think that potentially these nice translational research work will lead to risk scores that will help us choosing between an AI and tamoxifen. That will still require time because we will need independent validation of these tools. And finally, the host certainly matters, but unfortunately, we are not ready there to use the information in the clinic. You know that tamoxifen, in particular, is a drug that is metabolized through a series of enzymes. One important enzyme there is CYP2D6 because it leads to the active metabolite endoxifen. Here you see the correlation between the different CYP2D6 alleles and enzyme activity. And so you can divide the population into extensive metabolizer, poor metabolizer, intermediate metabolizer. There have been studies looking at CYP2D6 genotype and outcome under tamoxifen therapy, mostly adjuvant tamoxifen, and the data are completely inconsistent, as you can see here. There have been trials done in Europe, in Asia. In my view, these trials are very small, very underpowered. Some studies find an association, some studies don't. And then, of course, we know that there are drugs that are able to inhibit to a certain extent CYP2D6, mostly antidepressants, and they are listed there. And of course, we need to know which drugs in this aspect are safe for our patients. But unfortunately, at the ASCO meeting, we heard these 2 large studies looking at the use of drugs inhibiting CYP2D6. These are studies based on pharmacy databases. The American study suggested a relationship and a worse outcome if you use drugs inhibiting CYP2D6, but the European study did not show an association. So to make a long story short, among opinion leaders, I think there is a consensus that you should avoid using inhibitors of CYP2D6. But there is no consensus whether you should now go into the genotyping for CYP2D6. And finally, are we going to be able to accelerate the development of new drugs for hormone receptor positive breast cancer? And I just will share with you my view on this. I think that there are really fascinating data that were developed by Mitch Dossett and Jan Smith using the changes in Ki67 that you can detect after only 2 weeks of endocrine therapy. So the drop in Ki67 after 2 weeks of endocrine therapy is strongly correlated to relapse-free survival. And what is really nice is that this is now being validated prospectively in a very large randomized trial that just started in the UK, the POETIC trial. And what I think is that this potentially could be used to develop efficient drugs for these patients. And the question that my team has been asking is, can early readout of changes in gene expression signatures identify a responding patient more accurately than Ki67? So these are unpublished data, but very interesting. What we found is that, yes, a change in the genomic grade index can identify a patient responding to an aromatase inhibitor, and you can see that it is slightly better than Ki67. But what is more interesting is that we found that early changes in growth factor receptor signaling, like IGF-1 signaling, are also associated with response. But interestingly, we found that this only works in luminal B cancers. There are no relationship at all found in the luminal A cancers. So I will conclude by giving this message, which I think is important. We are dealing here with 2 completely different diseases. We need to separate them for research questions, and we need to start managing these patients differently in the clinic. The luminal B cancers are the subgroup most interesting for the exploration of new agents targeting growth factor receptor signaling, And for luminal A cancer and a high tumor burden, we will need to do a lot more work in terms of understanding the biology of these cancers. And this is just to thank my team and thank you all for your attention.